Can you see the screen? Screen
Yes,
share?
ma'am. Yes.
Okay. So we are starting the medically compromised, continuing it from page number 185, respiratory conditions. The first commonest respiratory condition which we see in practice is asthma. So the acute or status asthmaticus is outlined later in emergencies. First, the general management of asthmatic patients, what we need to do is given here. Advise patients with asthma to bring their reliever, inhaler, and spacer to the dental appointments. So, if the patient is coming for the first time, you would ask them if they are carrying it with them, or otherwise, you would, in the next appointment after history taking and all, you would ask them to bring in the next scheduled appointment. Patients with severe asthma are at increased risk of adverse outcomes from sedation and general anesthesia. Dental procedures requiring sedation or GA in a patient with severe asthma should be undertaken in a hospital with an anesthetist present. NSAIDs, example aspirin, ibuprofen, naproxen, can cause bronchoconstriction in patients with NSAID exacerbated respiratory disease. Cyclooxygenase 2 selective NSAIDs, celecoxib, do not cause bronchospasm in patients with NSAID exacerbated respiratory disease. So we have aspirin, the regular NSAIDs produce bronchoconstriction, but COX-2 selective inhibitors do not produce. So they can be given. Celecoxib can be given to asthmatics. If analgesia is required, asthmatic patients with known NSAID exacerbated respiratory disease, those who know that they get respiratory disease exacerbated by NSAIDs, we can prescribe either COX-2 selective or paracetamol. Patients with asthma can develop oral candidiasis secondary to the use of inhaled corticosteroids. So, this is asthma. Secondary to it is they are using inhalers, corticosteroid inhalers, and they get oral candidiasis because of immunosuppression. For the management of oral candidiasis, it was what we covered in the oral mucosal lesions, the same protocol of correcting the underlying disease and antifungal agents. To prevent recurrence, advise patients to rinse their mouth and throat with water and spit out after inhalation. Patients are sometimes prescribed a short course of systemic corticosteroids following an asthma exacerbation. Consider delaying elective dental treatment until the course is complete. Then we have COPD, chronic obstructive pulmonary disease. Now, dental treatments for patients with COPD may need to be modified according to the patient's condition. Patients with severe COPD do not tolerate being placed in a horizontal position. And patients with severe COPD are at increased risk of adverse outcomes for sedation and GA. So, what is the difference between asthma and COPD? Asthma is basically inflammation in the bronchioles, and it leads to constriction of the vessels. But chronicity in that constriction leads to chronic obstructive pulmonary disease. So it is, in asthma, it was more or less gasping for air. In this also gasping for air happens, but it is more or less that lumens are continuously getting constricted. Dental procedures requiring sedation or GA should be undertaken in the hospital settings. Patients with COPD are sometimes prescribed corticosteroids. Consider delaying elective dental treatment until their course is complete. Then patients with COPD can also develop candidiasis secondary to use of corticosteroids, like as was in asthma. And for management, oral candidiasis, go back to that and revise. In some patients with COPD, supplemental oxygen is contraindicated. Consult the patient COPD action plan. So basically, in both these scenarios, if the patient is able to tolerate general dental treatment and OPD, then only you will do in for asthmatics with their inhalers and everything bought in. But if they have any, you know, if they need any analgesia, which is you would prescribe paracetamol, and if they need any stress relieving or any medication for GA or anything, that would be done in the hospital setting, sedation basically. Then likewise is the COPD. It is best to refer them to hospital for sedation treatment under sedation basically. Then we have obstructive sleep apnea. Now, dentists have an important role in multidisciplinary management of obstructive sleep apnea, including diagnosis of facial, skeletal, retrusion or retrognathia, and construction of mandibular advancement splints. So what happens in these patients is when they are sleeping, the mandible falls back, it gets retrognathic, and tongue occupies the back posture, like it blocks the kind of an airway, and that leads to obstruction in breathing. Okay, that posture, that our pharynx, which is like a straight elevator behind you, see nose, oral cavity and larynx, there is a blockage at the level of oral and the nasal region, sorry, oral and the larynx region, because of the tongue falling back, and this tongue falls back because mandible is behind, because of which even if the patient is breathing from nose, there will be limited breathing, but there will be obstruction at the level of laryngopharynx and oropharynx. So that is obstructive sleep apnea. The patient would not be able to breathe efficiently, and because of the obstruction at this level. So then diagnosis by a general dentist is very important, and construction of mandibular advancement splints. It's something like twin block appliance, which is used for myofunctional therapy of growing patients where mandible is retrusive and it is just to position the mandible forward. So when mandible is positioned forward, what happens is tongue takes a forward posture, and the circulation of the airway, the breathing airway clearance happens. So that is the whole rationale behind it. Now, but this must be done in association with multidisciplinary team led by a specialist respiratory physician. The use of oral appliances for management of obstructive sleep apnea are reviewed in detail in American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine guidelines. Snoring may or may not be a sign of obstructive sleep apnea. It is not possible to diagnose the cause of snoring without medical examination and sleep laboratory investigation. Use of oral devices to treat snoring without such investigations is not appropriate. If it is suspected, refer the patient first for the medical assessment. Don't take the medical examination lightly in these cases. First, send them for first medical examination and then proceed to oral devices. Use of oral devices to treat snoring without medical examination and investigation is inappropriate. Patients with obstructive sleep apnea are at increased risk of respiratory arrest from sedation and GA. Again, dental procedures requiring sedation and GA in a patient with obstructive sleep apnea should be undertaken in a hospital with an anesthetist present. So this completes our three scenarios or three areas of respiratory disorders, we will proceed to viral hepatitis. Now, viral hepatitis, it's a infection by the virus, and hepatitis, we know that it is A, B, C, three types of viruses are commonly there. And it's a blood-borne infection, especially the virus B and C. So that's why it's very much important to follow that infection control guidelines and be cautious of hepatitis spread in dental setting. Now, the most relevant hepatitis viruses to dental practice are blood-borne viruses that cause chronic liver disease and cirrhosis, hepatitis B and C. So most cases of hepatitis B can now be cured with antiviral therapy. Patients with chronic or untreated hepatitis C have a higher incidence of oral lichen planus, dental caries, and periodontal disease. Periodontal health in particular is markedly poorer, and salivary flow is reduced in patients with hepatitis C. Whether this is a direct viral effect or due to other causes is unknown. Preventive dental care and management is particularly important for patients with hepatitis C because the outcomes of major restorative treatment may be poor. Then, before proceeding with an invasive dental procedure in a patient with chronic viral hepatitis, consider the potential coagulopathy and immune compromise associated with end-stage liver disease. So, in viral hepatitis, because vitamin K dependent factors are not produced because of liver involvement, there can be coagulopathy and immune compromise, which is because of the liver disease. Consult the patient's treating specialist or multidisciplinary team to determine an appropriate treatment plan. Include antibiotic prophylaxis. In this condition, we would need to ask the patient specialist or consult with him regarding antibiotic prophylaxis also. Avoid sedatives and NSAIDs in patients with viral hepatitis because they can cause liver toxicity. Paracetamol can be used at normal therapeutic doses. However, it is particularly important to ensure that the maximum dose of paracetamol is not exceeded because patients with viral hepatitis are at increased risk of liver damage at supratherapeutic doses. So, these patients, because of the liver disturbance, cannot take much of the heavy-duty medicines. All the medicines get metabolized with the help of liver. So that's why paracetamol, though, can be given at normal therapeutic doses, but we have to make sure we do not exceed its therapeutic maximum dose, which is 4 grams for a day for a normal 60 kg patient. And to select appropriate analgesic, like we read in the analgesic dosing. Moving on. Antibiotic prophylaxis for dental procedure. So this is a highly important area when we give antibiotics for prophylaxis, for prevention of the infection. Now, overview of antibiotic use for dental procedures. Only use antibiotics before a dental procedure if there is a clear indication for their use. Surgical antibiotic prophylaxis rarely indicated. So before doing any surgery, we do not give patient, okay, today is your impaction surgery. We would give you antibiotic in advance, 1 hour before procedure. That is usually not done. Then infective endocarditis prophylaxis is needed for patients with specific cardiac conditions. So we will go with what it is needed. Undergoing specific dental procedures. So there are set of cardiac conditions, then set of dental procedures. Both should there be combined areas where we have where we will choose, okay, these cardiac patients undergoing these procedures, we will give infective endocarditis prophylaxis. It is given even if surgical antibiotic prophylaxis is not indicated. And antibiotics to treat acute odontogenic infection may be required even if surgical antibiotic prophylaxis and infective endocarditis prophylaxis are not needed. So this is actually the infection has happened. So this is to treat. It is somewhere a misnomer. It shouldn't come as such under prophylaxis part. So this we have already covered in the previous spreading infections and dental infections without systemic involvement, all those categories. Then we have going to surgical antibiotic prophylaxis in dentistry. It's rarely indicated. The recommendations to use surgical antibiotic prophylaxis are informed when possible by evidence that prophylaxis is beneficial for relevant procedure and patient group. Further, the potential benefits of preventing post-op infection with surgical antibiotic prophylaxis is balanced against the potential harms of antimicrobial use, which is diarrhea, rash, bacterial resistance. Then the role of surgical antibiotic prophylaxis for patients with profound immunocompromise or assessing for guidance, we can see what is the patient's degree of immunocompromise who are undergoing invasive dental procedure is uncertain. We cannot be very certain about need for antibiotic prophylaxis. So discuss this with the treating specialist or multidisciplinary team. Then we have surgical, again, they have highlighted that it's rarely indicated for dental procedure. Even if it's not indicated, consider the need for treatment of acute odontogenic infection or infective endocarditis prophylaxis. And for the role of surgical antibiotic prophylaxis before dental procedures in patients with, we will have a separate read on prosthetic joint or a breast implant later. Okay, do not use prophylactic antibiotics in dry socket cases because it's a post-extraction complication caused by premature clot lysis rather than infection. So it is not an infection per se. Just that clot is lysing, it is not able to clot well in there. We will read about dry socket later. And then we have dental procedures and their requirement for surgical antibiotic prophylaxis. So tooth extractions, third molar surgery, dental implants, periodontal surgery, periapical surgery, any soft or hard tissue removal, we do not give surgical antibiotic prophylaxis. Anything? It is as a general dentist scope, we do not give, but with profound immunocompromise, if a patient comes, we would discuss the need for surgical antibiotic prophylaxis with multidisciplinary team or treating specialists. Then we have, again, they have highlighted in the box principles. Do not use surgical antibiotic prophylaxis unless there is clear indication. The choice of antibiotic is determined by susceptibilities of the organisms. So we actually check which could be the organism, maybe culture and sensitivity, which would cause these post-operative infection. And if prophylaxis is indicated, single pre-operative dose of antibiotic is usually sufficient. Post-operative doses are not required. And then surgical antibiotic prophylaxis must be administered before surgical incision. For short-acting antibiotics, amoxicillin should be administered no more than 60 minutes before the incision. So 60 minutes, 1 hour before the procedure, amox should be given. We would have in detail about this in infective endocarditis prophylaxis. If a patient has pre-existing joint prosthesis, like knee joint replaced or anything, these surgical procedures can result in incidental bacteremia. There is a low risk of seeding of the joint prosthesis and subsequent infection. So accumulated evidence supports the same approach to surgical antibiotic prophylaxis for patients with and without pre-existing joint prosthesis. So you can proceed with the treatment as a normal patient. Neither the indication for prophylaxis nor the choice of antibiotic regimen is altered by presence of joint prosthesis. This is true even for procedures that commonly cause bacteremia. And okay. So even if you are doing tooth extractions or periodontal procedures which are causing bacteremia, this is even true for those procedures also. The potential adverse effects outweigh the potential benefits of prophylaxis. So it is meaning they are trying to say that adverse effects of giving antibiotic prophylaxis for the extractions, periodontal procedures, etc., are more than the potential benefits of giving these prophylaxis. And they have highlighted again, only give surgical antibiotic prophylaxis to patients with a pre-existing joint prosthesis or breast implant if prophylaxis is indicated for the procedure. Then we have surgical antibiotic prophylaxis for patients with a pre-existing breast implant. Neither the indication for prophylaxis nor the choice of antibiotic regimen is altered by the presence of breast implant. Therefore, the same approach to surgical antibiotic prophylaxis should be taken for patients with and without a pre-existing breast implant. So same thing like joint replaced, we have for breast implants also. But if we are choosing to give antibiotics, which antibiotics should we go ahead with? If prophylaxis is indicated, example, after discussion with the specialist or multidisciplinary team, we found that it is needed for profoundly immunocompromised patient undergoing an invasive procedure. A single preoperative dose of narrow to moderate spectrum penicillin is usually appropriate. Clindamycin is suitable alternative for patients hypersensitive to penicillins. The regular, like we always choose clindamycin in patients hypersensitive to penicillins. Then consider the principles of appropriate prescribing of surgical antibiotic prophylaxis. The choice of antibiotic for surgical prophylaxis may not need to be altered in patients who have recently received antibiotic therapy. And for patients who have taken a short course of antibiotics for an unrelated illness within preceding 4 weeks, you need not modify antibiotic choice. So if the patient has had a course of, say, Amox, you can again give Amox. No need to modify antibiotic choice. For patients who have received surgical antibiotic prophylaxis, patients for whom a dental procedure is completed over multiple sessions, there is no need to modify antibiotic choice again, even if using the same antibiotic each time. So every time, same amoxicillin is to be maintained. And for patients taking long-term antibiotics for another indication, say rheumatic heart disease, they are already on benzyl penicillin for rheumatic heart disease, it may be necessary to modify antibiotic of choice because now it is normalcy for them. That dose is just keeping rheumatoid heart disease at bay. But if we are choosing to give surgical antibiotic prophylaxis, we need to top up, change another medicine which can take care of increased threat of infection. So this completes our need for surgical antibiotic prophylaxis. The next segment is prevention of infective endocarditis. Now, infective endocarditis prophylaxis, we have to cross-match in the, it is very important to know about rationale for infective endocarditis prophylaxis. Now, it is relatively uncommon illness with high morbidity and mortality. So prevalence is less, it's not very common, but if it happens, it has high morbidity and mortality. Incidence is 5 cases per million. And in terms of hospital mortality, it is 15 to 20% in hospital mortality. So for many years, antibiotic prophylaxis was routinely given before dental and other procedures to patients with cardiac conditions that have high lifetime risk of infective endocarditis. So for the previous guidelines or recommendations were like were for giving infective endocarditis prophylaxis. However, endocarditis after these procedures is rare. So prophylaxis prevents very few cases. So they had done a lot of research and found out that very rarely we actually reach that stage of need to give the surgical antibiotic, need to give antibiotic prophylaxis for infective endocarditis. Because their rationale is that endocarditis related bacteremia is more likely to result from daily oral hygiene activities than from specific dental procedures. So it is strongly associated with poor oral hygiene and gingival disease. So a patient brushing daily will create that much of, if he is having a poor oral hygiene, that will create that much of spatter or bacteremia, which would be much more than drilling or scaling. Okay? Therefore, maintenance of good oral health and hygiene is more important than use of antibiotic prophylaxis. Oral hygiene is more important for general population, but particularly for patients with cardiac condition. Endocarditis can occur after hospitalization, especially in older, sicker patients with diabetes and chronic kidney disease. So we have two more comorbidities which can lead to endocarditis. This does not appear to be a sequel to a particular procedure, but rather to problems such as intravascular catheter infections. This emphasizes the need for infection prevention and control strategies in hospitals. So no randomized control trial has been performed to determine its role, because we cannot give antibiotic prophylaxis versus not do, and wait for infective endocarditis to set in. So there are no human studies showing it can prevent infective endocarditis. Consequently, the guidelines rely on expert consensus. So if we do not have the proper human research, experts consent or consensus, joint decision making gave us these guidelines. Since 2002, many international guidelines have significantly reduced the number of indications for infective endocarditis. The previous guidelines, the NICE, okay, from UK, went even further in 2008, recommending that antibiotic prophylaxis was not required for any person before dental or other procedures. Then we have studies examining impact of changes in guidelines have yielded conflicting results. The patients can come whose previous dentist did some dental procedure previous to 2000 to 2008, and they say I was given antibiotic prophylaxis previously, why you are not giving me? So that is where conflicting results can come. Some studies indicate that incidence of infective endocarditis has not increased with restricted or no prophylaxis, but other studies suggest that it has increased after adoption of new guidelines. In response to these data, NICE modified their recommendations in 2016 to state that infective endocarditis is not routinely required, prophylaxis is not routinely required. This update allows for clinical judgment to decide if endocarditis prophylaxis is required. So 2016 is the date when they say that it is not routinely required. One blanket statement is, you will tell to your patient it is not routinely required, but you will do a clinical judgment for that particular case, and finally it will come to boil down to your clinical judgment. In absence of high quality evidence, antibiotic expert groups continue to recommend antibiotic prophylaxis against infective endocarditis for restricted group of patients. And now we will read the indications for it. In what restricted group we should give? Okay, we have, it is only recommended indications now we are reading only for patients who meet both of the following criteria. So two criteria should be overlapping both if they meet. One is cardiac condition associated with increased risk of developing endocarditis and high risk of adverse outcomes from endocarditis. So what are those high risk conditions? We will read in the box 24. And these high risk patients are undergoing high risk procedures which produce bacteremia that is associated with endocarditis. And it is not recommended for situations other than those covered in this topic. Only for patients with following cardiac conditions. So let us see what are the cardiac conditions where we will prescribe or give infective endocarditis. Prosthetic cardiac valve. Patient is having an artificial cardiac valve present, including transcatheter implanted prosthesis or homograft. Same means from his own body if he's having graft into the heart. Then needed. Artificial cardiac valve needed. The patient factors say that it is needed. And prosthetic material used for cardiac valve repair. Either the valve is prosthetic or material used to repair it is prosthetic. Then previous infective endocarditis infection has happened. Congenital heart diseases, but only if it involves unrepaired cyanotic defects. Cyanotic defects are the one which are producing bluish hue, which are producing cyanosis. Then unrepaired defects with residual defects at or adjacent to the site of prosthetic patch or device. So whenever prosthetic patch device repair material is coming, they come under the high risk category. And rheumatic heart disease in high risk patients. Now this was the risk category of patients, but risk category of disease should also complement for us to decide. Okay. So it is only to be given in patients in box 24 and only dental procedures involving manipulation of the gingival or periapical tissue or perforation of the oral mucosa like extraction, implant placement, biopsy, removal of soft tissue or bone, subgingival scaling and root planing, reimplanting avulsed teeth. So all this, if we are manipulating gingiva or periapical tissue or mucosa in any manner, then only it would be needed. So it won't be needed for, say, placing brackets. It won't be needed for supragingival scaling. It won't be needed for cavity preparations, restorations, composite restorations, amalgam restorations, not needed. Then we have, it is thought that Aboriginal Torres Islander people with rheumatic heart disease are at high risk of developing infective endocarditis and adverse outcomes from the disease. So this category of information is very important because question STEM can say that an Aboriginal Mr. X came to you for so-and-so treatment. So you have to pay attention that they have a higher risk of developing infective endocarditis. However, it has been argued that the higher risk, poorer outcomes are associated with socioeconomic disadvantage rather than ethnicity. New Zealand guidelines recommend prophylaxis for all patients with rheumatic heart disease, specifically Maori and Pacific Islander people. It is the consensus view of antibiotic expert groups that antibiotic prophylaxis should be administered to all Aboriginal Torres Islander people with rheumatic heart disease who are undergoing certain procedures. So if they are going this implant placement, extraction, gingival, periapical tissue, oral mucosa procedures, you would give antibiotic prophylaxis. It is the consensus view. Other patients with rheumatic heart disease who are at significant socioeconomic disadvantage should also be considered for antibiotic prophylaxis. So socioeconomic disadvantage, you can, and going such procedures should be given, can be considered to be given this. This completes our